So looking at everyone's age in here, probably half of y'all got it, if not more. And there's an old saying, it ain't if you're going to get AFib, it's when you're going to get AFib. Because if you live long enough, the odds of you getting AFib is extremely high. Okay? So what is AFib? So you have two chambers at the top of your heart and two chambers at the bottom of your heart. And if your heart's beating 60 times a minute, the normal way God made it is the top chambers beat. There's a little timing mechanism through the electrical system, then the bottom chambers beat. When you're in AFib, your top chambers are actually beating like 600 times a minute. And if your bottom chambers beat 600 times a minute, you drop dead. So God made it to where your bottom chambers cannot beat 600 times a minute. But it can beat in the 150s, 180 range. So what it is, the top chambers of your heart are beating 600 times a minute. And they're not squeezing like this. They quiver. Essentially, they're at a standstill. But because of the braking and electrical system through your heart, like I told you, your bottom chambers can't beat that fast. The most your heart can beat is 220 minus your age. So if you're 20 years old, your heart can beat around 200 times a minute. And that it may make you feel bad, it may make you sick, may make you short of breath, but that doesn't kill you, and it doesn't really make you pass out. So it's good that God made it that way, that you have a braking system where your top chambers can beat 600 times a minute, but your bottom chambers can't. So what's the big deal about AFib? Why do you need to be concerned about it? AFib does several things. The number one thing that our concern is with AFib is strokes, or let's just say embolic clots formation. Embolic means that a clot breaks off and goes somewhere. Now, we always talk about strokes, but I have a patient from Winsboro who infarcted his kidney. He went to every doctor in the world. All they looked at it was his kidney, his kidney, his kidney, his kidney. They were doing angiograms and all this stuff, and no one ever did an EKG on him. He was in AFib, and instead of the clot going to his brain causing a stroke, the clot went to his kidney and infarcted his kidney. So the clot doesn't say, hey, I got to break off and go to the brain. It'll go anywhere. You can lose a toe. We've had people that have blockages in their legs. It breaks off and cuts the blood flow off to their leg. So the clot can go anywhere. But the most concerning place, obviously, is a stroke. I've had people with heart attacks where the clot breaks off and then goes down the coronary artery and causes a heart attack. So the clot can literally go anywhere. But most of the time, we always talk about stroke, stroke, stroke. So that's the number one thing about AFib is stroke risk or clot risk. Now, the other thing it does in most people is make your heart beat really fast and irregular. And when I say really fast, I mean 150, 160, 130, 180. And it's not regular. AFib is described as an irregular rhythm. That means there's no method to the madness of when it's going to go through. And so when you're in an irregular rhythm and you're beating fast, that's not the way your heart was meant to perform. So your heart is not performing the way it's meant to be. People get short of breath. They can go in heart failure. Lots of different things that fast, irregular heartbeat causes. With that said, every week we have people walk in the office in AFib that have no idea they're in AFib. They don't even know it. We find it by accident. And so those people have AFib, and their heart might be beating 120 and they have AFib, but they don't even know it, they don't feel it, they have zero symptoms. Some people go in AFib and they can't walk from here to across the room. They're so short of breath and symptomatic. So those are the two things that AFib does. It causes embolic strokes or emboli to certain parts of the body, and it makes your heart beat fast and irregular, And at some point, in some people, the majority of people actually, that causes symptoms. So that's the definition of AFib. That's why you need to be concerned about AFib. And that's sort of the introduction of this. So what y'all need to know is this. What do you do about it? Okay? Because, now I want everybody to pick up this sheet of paper. If you have it, it says CHAS-VAS score. Okay? So people will come to my office and say, I had AFib, you put me on this pill, I haven't had any AFib since then, can I come off my blood thinner? Okay? Whether you can have to take your blood thinner or not has nothing to do with whether you're in AFib or in normal rhythm. Has nothing to do with it. Whether you need to be on a blood thinner or not is 100% based on your CHAD-VAS score. The reason why is because unless you're wearing a monitor 24 hours a day, 7 days a week, we know by checking people's pacemakers and putting monitors on people that even though they think they're not having AFib, they really are having AFib. And so if you're having AFib and you don't realize it, you're still at risk for the stroke. So that's why normal rhythm versus AFib has nothing to do with whether you should be on a blood thinner or not. If you have AFib, and then you look at the CHAD score, so everybody look at it. If you have congestive heart failure, you get a point. You have high blood pressure, you get a point. If you're over 65 years of age, you get a point. If you're over 75 years of age, you get another point. If you're a woman, you get a point. If you have history of a stroke or a TIA before, you get a point. If you have heart disease, if you have diabetes, you get points. You get 2 points if you've had a stroke before, and you get 2 more points if you're over age 75. So let's take a 78-year-old woman who's had hypertension, diabetes, a previous stroke, and heart disease. Well, her CHAD score is super high. It's up there in the 8 or 9 range. Look at the bottom of that little corner there. That's your stroke risk. The higher your CHAD score, the more likely are you're going to have a stroke. So if you're 20 years old, healthy, and there are people like this. I had a guy who was 24, 25 years old. He was an AFib, didn't know it. He don't have to be on any blood thinner, ever, until he gets older. Why? Because his CHAD score is 0. And when your CHAD score is 0, the risk of stroke is lower than the risk of bleeding on the blood thinner. So we don't put you on the blood thinner because there's no risk-benefit ratio. Okay? So that's one thing that's very common that I can teach all y'all, because half of y'all done asked me that question 1,000,000 times. Can I get off my blood thinner? Can I get off my blood thinner? Can I get off my blood thinner? And the answer is no, you can't get off your blood thinner because your CHAD score is 4. Your CHAD score is 5. So the number we mostly use is CHAD score 2. And some people, if it's a woman, sometimes we use 3. But somewhere around a CHAD score of 2 or 3 is what determines whether you need to be on a blood thinner or not, the rest of your life. Now, obviously when you need a procedure done, you got to have a tooth pulled, colonoscopy, whatever. You stop the blood thinner, do what you got to do, start it back. But other than that, you're dedicated to blood thinners for the rest of your life. So that's the one thing you need to know. Now the other thing you need to know is this, and this is, most doctors don't know this. There is absolutely no reason whatsoever, if you're in AFib and you have no symptoms, your heart rate's controlled, your heart rate's 80, 70, you're in AFib, how do you feel? I feel great. Can you do what you want to do? Yeah. Can you walk up a flight of stairs? Yeah. Do you get short of breath when you clean your house? No. Any symptoms at all? No. Absolutely no reason whatsoever to have to put that person in normal rhythm. It's a waste of time. There is no benefit from putting somebody from AFib to normal rhythm unless you're having symptoms. If you're not having symptoms, because what did I just tell you, you're going to be on your blood thinner forever anyway. Now, if you're young, and when I say young, I mean in the 40s, 50s, 60s even, then it might be worth trying to put you in normal rhythm. And sometimes it's always worth at least to try once to put you in normal rhythm. And the way we put people in normal rhythm, usually there's choices. One is medication, but the best medicine we have only works 50 to 60% of the time. So that means there's already a 50% chance that I'm going to give you a pill to try to keep you in normal rhythm and it's not going to work. The other thing you need to know is that the ablations. So the ablations, if you add ablation to the medicines, that works about 80% of the time. So there's still a 20% chance you're still going to have AFib forever, back and forth on and on. So the only reason why I would do it is someone young, so that you might be able to save them over time from maybe not having to take, because their CHAD score is low, and the longer you're in AFib, the less likely you're ever going to get back in normal rhythm. So young people we might treat a little bit different, because I do have patients in their 20s and 30s and 40s and 50s that have AFib. We're more aggressive with them on trying to get them to maintain normal rhythm. But if you're in AFib and you don't know it, thin the blood, control the rate, and say sayonara. That's all you got to do, okay? If you're having symptoms, that's the people we're very aggressive with on trying to get back in normal rhythm, so that you can do the things you want to do and not have symptoms. But I guarantee you there's people out there in this audience right now who doctors have been working all years trying to get you back in normal rhythm, and you don't even know you're in AFib. They do it all the time. So the other thing you need to do is treatment options. So what are our options for treatment? Okay? So aspirin is useless. You taking a blood thinner? I take aspirin. Well, guess what? It ain't doing you no good. It's useless for AFib. 100% useless. The only medicines that work for AFib from a blood clot standpoint is either Coumadin, the old-fashioned blood thinner, or what we call DOACs, which is Eliquis, Xarelto, Pradaxa, those medications. And that's for people who do not have valvular AFib. So that's another point you need to know. The only real valvular AFib is mitral stenosis. And that's very rare in the United States. It's very common in third world countries because they get rheumatic fever. But other than mitral stenosis, that's the only time that, because you hear that on TV, if you don't have AFib not due to a heart valve problem. When they say heart valve problem, they mean mitral stenosis. Aortic stenosis doesn't count. Mitral regurgitation don't count. Aortic regurgitation does not count. Only mitral stenosis. So if you do not have mitral stenosis and you have AFib, your choices are Coumadin versus the DOACs, which is Eliquis and Pradaxa and Xarelto. If you have mitral stenosis, you have to take the Coumadin. If you have a prosthetic valve, a metal valve, or valve surgery before, then you would have to take Coumadin. But if it's just a leaky mitral valve or an aortic valve problem, you can still take the DOACs and you don't have to take Coumadin. So what's the advantage of Coumadin versus the DOACs? Well, Coumadin, everybody's different. I might be on 5 milligrams, he might be on 10, you might be on 2.5, she might be on 15. And so you have to adjust the dose for everybody, you have to check it. It's kind of a pain for you and a pain for everybody else. So we've almost 100% exclusively switched to Eliquis or Pradaxa or Xarelto. The difference is the cost, and that's the only problem is they're expensive. And so most insurance companies, if you have some kind of copay or whatever, they're more than happy to cover it because you don't have to get your blood drawn so often and there's less complications. But you have to be on some form of a blood thinner. So then now the big thing is the Watchman device, and I'm sure y'all have had talks on that too. So if you cannot take blood thinners, and there's a list and there's a little thing showing y'all what the Watchman is. Over 90%, probably like 95% of all strokes from AFib comes from this what's called the atrial appendage. It's about the size of your thumb, and you can see the picture of it on your little screen. That's where all the clots form. So for years, we've been doing different things to that atrial appendage to try to keep it from forming the clot. If you don't form the clot, then you can't have the stroke. So the biggest thing out right now is called the Watchman. Before, they had to you could surgically remove the atrial appendage when you went for open heart surgery. But when the Watchman device came out, we go through the vein in your leg, we run across from the right side of the heart to the left side of the heart, and we leave this plug, for lack of a better term, inside the atrial appendage. And over time, your body grows tissue over it and seals that up. Now, you would still have to take your blood thinner for approximately 45 days afterwards. So who gets Watchman? So the majority of the time it's because people bleed on the blood thinners. And so every time we put them on blood thinner, they get a GI bleed from somewhere and you have to stop it, and then you try to start it back and they bleed again. So that's the number one reason why we put it in. There's other reasons why you can put it in. You have to every patient's different. Some people can't afford, under any circumstances, can't afford $400 a month, which most people can't, to buy the expensive blood thinners. And then the Coumadin, sometimes, people on Coumadin, you can't keep it controlled, and that's not uncommon. And so that would be an indication to say, well, you're failing medical therapy and we can put a Watchman in you. You still have to take the blood thinners for about 45 days after, but hopefully, now there's a new one out called an amulet, where you don't have to take you have to still take blood thinners for 30 to 45 days after, I think it is. I'm not 100% sure on the time. But you can just take aspirin and Plavix for those. You don't have to take the Eliquis or Xareltos and stuff like that for that particular model. It got FDA approved without having to take those. They could take aspirin and Plavix after the procedure because it works different than the Watchman does. But so there's a second one out. It's just now coming on the market and not being widely used yet. But so we do Watchmans here. We do a lot of them. Dr. Smith does them. I'm starting to do them. Dr. Manrique does them. He's fixing to leave town. That's kind of about why I started getting into them, because it's really like a two-man job. So it'll be me and Dr. Smith doing those. But and Dr. Smith's done a lot of them. But that pretty much sums up the AFib business. So the take-home point is AFib is very common. It's not when you're going to get it. It's not if you're going to get it. It's usually when you're going to get it. And it's mainly the biggest risk are fast heartbeat, irregular heartbeat, making people have symptoms. Some people do not have symptoms. You must thin the blood because of the risk of strokes based on your CHAD-VAS score, not based on whether you're in normal rhythm or not. And whether you need to be maintained in normal rhythm is based on your symptoms and symptoms only, and maybe your age is how I kind of approach it. And the other thing is you must maintain blood thinners, and your options are the Coumadin, the DOACs, or a mechanical device such as the Watchman. That's pretty much it. I was going to take some questions and go from there. Now, if it's a long, extended question, I'm going to go ahead and charge y'all an office visit.
How do you tell the difference between preventricular fibrillation and atrial fibrillation?
You're talking about preventricular contractions.
Yeah, contractions.
Because the ventricle, the answer is in the word. The premature ventricular contractions come from the ventricle, which are the bottom chambers.
It's not as dangerous, right?
Well, it depends. It could be more dangerous. If you have a bunch of PVCs in a row, that's called VTAC, which is more dangerous than AFib. But AFib comes from the top chambers. Ventricular contractions come from the bottom chambers. Well, this is a talk on AFib. I got 2 PVC questions. So it's the same thing I just told her. They come from the bottom chambers of your heart. And again, if they're not causing a problem, we don't do anything about them. If they can make your heart weak, and if your heart becomes weak because of them and the medicines don't work, then you have to have an ablation to get rid of them. But if you have asymptomatic PVCs, you don't need to have anything done to them.
What is your favorite heart-healthy meal?
It depends. It used to be spaghetti and meatballs. The only diet that's been shown to be heart healthy at all is called the Mediterranean diet. All the other ones are never been clinically proven to be beneficial for anything.
What is the new thing besides the Watchman? And we're not doing it here in Monroe. Are they doing it in Shreveport?
Well, the only reason why we're not doing it here in Monroe yet is because it's so new that the company hasn't been able to launch it everywhere.
And what is it?
It's called an Amulet. It's made by Abbott instead of Boston Scientific. It works almost the same way. The only difference is the Watchman goes in there and stays in there. It's just one piece. This is like a two-piece. You stick the thing that looks just like a Watchman inside the appendage, and then you kind of slide what looks like a garbage can lid over the wire and screw it together. So it kind of pancakes it. So you got the ball, which fills up the appendage, and then you have this other thing that comes and smashes it and kind of just makes a seal. See what I'm saying? And that's why you don't have to take the blood.
Have they started anyone in Shreveport?
I have no idea because, like I'm telling you, they're still training right now. So probably the only people that are doing it right now are the people that were in the study from the original thing. So unless they were in the study, they're probably not doing it in Shreveport yet. If they were in the study, they probably are. Because everybody's got, we're going to go get trained for something else. There was Abbott came out with a new leadless pacemaker. And I mean, whenever you go get trained, they just fill up so fast that it's hard to get everybody trained. So it takes about 6 months to a year when something comes out for it to be, available at most places. Any other questions?
What are some of the symptoms of AFib to let you know that you really
So most people, like short of breath is the number one, and feeling your heart beat fast and irregular. But mainly it's just you can't, in some people that atrial kick, being in normal rhythm, is responsible for up to 30% of your cardiac output. So if your heart's, already stiff or already weak a little bit, and then you lose 30% of that, it just makes you more tired, more fatigued, more short of breath. And then you can feel your pulse and tell, if it's beating fast or irregular. Anybody else?
What about clots breaking free from other parts of the body? Your neck or your...
Well, that's not from AFib.
I know, but, they clots for stroke.
So most strokes that occurred from like carotid disease you're
Yeah.
talking about? Yeah, what happens is most of those are due to a little plaque that ruptures, a clot forms, breaks off, and causes a stroke. It's the same thing kind of, but instead of coming from the heart, it's coming from the carotid artery. Yeah, decreased energy. Just, people describe everything, people come in there and some people are horrible at trying to describe what's wrong to them. They come to, what's wrong with you? Well, I'm tired. Well, I mean, hell, there's a list from here to 165 of what can make you tired. You see what I'm saying? So it can kind of do anything, but majority is just like whatever you would think that would be something that would make, it'd be like if you had a motor and it was, you had a 6-cylinder motor and you pulled a couple of the spark plugs off. It's still going to run, but it don't run like it's supposed to. So if you don't feel like you usually do, then that's usually, could be the problem. But yeah, it makes you tired, makes you fatigued, the main thing is people that short of breath. Some people just present with heart failure. They come in and say, what's wrong? Well, my legs are all swollen. And so they're in AFib, So, it can present as heart failure, it can present as just generalized fatigue, and most people present, they feel their heart beating fast, stuff like that.
you need a pacemaker?
Well, the pacemaker don't do anything to prevent an AFib. So the only time you would need a pacemaker is if some people have what's called tachy-Brady syndrome. Tachy means fast, Brady means slow. So what happens is when you're in AFib, they're beating 150 times a minute. You give them a little bit of medicine to slow them down, they're beating 40 times a minute. You stop that medicine, they go back to beating 150 times a minute again. So then you're stuck between a rock and a hard place. And in those people, we put a pacemaker in them, and then we don't got to worry about them getting too slow anymore, and we can give them anything we want to keep them from beating too fast. So we do use pacemakers a lot in AFib, but not to keep you from beating in normal rhythm. There are log rhythms they can put on the pacemaker and all this kind of stuff, and they try to sell it as, you know, it helps prevent AFib, but none of that really works. The only time you really use a pacemaker in AFib is when you're having either when you beat too slow when we try to slow you down. There's a guy today I caught the other day, he's symptomatic, very symptomatic, big heavy set guy. Shocked him back in normal rhythm, put him on some medicine. When we got through shocking him, his heart rate was 49. So I kept him overnight, it came up a little bit, I'm going to put a monitor on him. So that's an example. Almost every medicine except one that you use to control someone's AFib makes the heart slow. And some people, it makes it too, when they're in normal rhythm, they're too slow. And if you stop it, they go back in AFib and they feel bad. So in those people, you put a pacemaker in them, set it at 60 or 70 or whatever, they'll never get slower than 70, and you can give them all the medicine you want to keep them from having AFib beating real fast. So that's when we use pacemakers with AFib. I did so good, there's no more questions? Well, there's systolic heart failure and what we call diastolic heart failure. And essentially, it means that things are backing up, fluid's backing up, okay? So if your heart's weak, it doesn't pump strong, and it all has to do with pressure, okay? So a weak heart doesn't pump good, fills with blood, pressure builds up in your lungs, goes to your veins, the pressure in the veins are high, leaves the veins, makes your legs swell. Then there's diastolic heart failure. Your heart pumps super strong, but the heart don't stretch. And it has to stretch to fill with blood, right? So if it doesn't stretch, pressures builds up in your lungs, builds up in your veins, the fluid leaves the veins and goes into your tissues and your legs swell. So when you're in AFib, you know, all that's based on what we call your cardiac output. So it's real simple. That's why I went in cardiology. If you can't understand it, something's wrong with you. It's no different than, it's like a pump, okay? You got a pump. You got water in your boat, you're sinking and you're trying to get the water out. And so if your heart's weak, it's like trying to bail the water out of your boat when your bucket has a hole in it. You don't get anywhere. If you got too small of a bucket and it's raining, you're going to sit there and work your butt off, but you're not getting anywhere because your bucket's too small. The same thing with heart failure. And so AFib, if it's responsible for 30% of the pumping the water out, and you go into AFib and you're inefficient, you know, it's like putting a hole in your bucket. You know, you're working real hard, but you're not getting anywhere.
So is there a hereditary factor to atrial failure?
I guess it could be. I don't think there's not like the genetic testing you can do and say, oh, you're going to have AFib. Most of it is. I can tell you what, sleep apnea is the number one thing for AFib for younger people. If you got sleep apnea, you're going to have AFib. And almost everybody's got. I can think of 5 people out of thousands that I've sent for a sleep study test that came back normal. I mean, everybody's got it. So, weight has a big thing to do with it. They say if you lose I mean, it's dramatic, the decrease in, I can't remember the number, but the number's dramatic in decreasing your AFib burden based on losing a lot of weight. So,
Can channel blockers or beta blockers cause AFib?
I don't think they would cause AFib. I guess if you got your heart too slow, but usually that's the medicines we use to treat it with. Usually stimulants is going to cause AFib.
The relative cause you to bleed, I mean, to bruise easily.
Yep. I get people all the time. They're 85 years old. They raise their arms up and says, "Look at all these bruises." Or my leg, yeah. And I said, "Well, I don't think you're fixing to enter any beauty contest. It's better off to it's better to be bruised on the outside than bruised on the inside." Like that.
That don't bother
It don't bother. It shouldn't bother
me.
you.
It does not bother me.
Good.
I'm just proud to be 89.
That's right.
89.
I tell them, I said, go to the graveyard and yell as loud as you can. How many of you 90-year-old people wish y'all had a bruise? Every one of them raised their hand out of that grave. Yeah. Anything else? All right, I think that's it. I appreciate y'all.
Thank you, Dr. Sampognaro, and please thank your wife for us for encouraging you to come out today. Oh, no. I think it's very fitting that we're talking about the heart today because a few days ago, our hearts were saddened by the passing of one of our colleagues and employees and friends, Shara Fertitta. Shara served as the educational events coordinator for Vantage and had a very special place in the heart of our company. She was a wonderful ambassador for Vantage and will truly be missed. And if you don't mind, I'd like to share a few comments for some of our executives and some employees. Shara was one of a kind individual whose bright light spread throughout the company. She worked hard to help others and to bring value to each person's life. That was Michael Eccles, our Director of Business Development. Shara was a very committed community advocate. She loved working with people and providing helpful information to the senior citizens in our community. That was Mr. Mike Briard, our Executive Vice President. Mr. Robert Bozeman, General Counsel for Vantage, said that in 2007, Vantage was at risk of losing its ability to offer plans to the Office of Group Benefits. When Vantage fought back through the court, Shara, as an OGB member, joined in the federal court lawsuit in Baton Rouge, which Vantage ultimately won. I had the privilege of representing Shara in that case. She was a wonderful person, and because of her courage in standing up for Vantage when it was most needed, we have survived, grown, and prospered. And Ashley Solar, who is our Events and Facilities Coordinator, said that Shara was the most beautiful soul that touched so many people near and far. She was a bright light that shines so brightly in this tough world. Her smile always made your day better, even when it was the worst of days. Shara was a former educator, and as our senior wellness events educator, she brought so much joy and love to everyone's lives. Please keep Shara's family, friends, and coworkers in your thoughts and prayers in the days ahead as they go through this difficult time. And now as we close this afternoon, we'd like to share with you a special video tribute in memory of our friend and colleague, Shara Fertitta.